And so all of these questions, and of course at the most fundamental level, are the key concepts that make up the field: sex, assigned at birth, gender identity, transgender adolescent. What do these terms mean? Do they have a scientifically valid definition? To what extent are they at play in this area of medicine? And if the answer to those questions is that no, these terms are not, they're not well defined, they don't have scientifically valid definitions, is that a problem for the field? Imagine if endocrinologists were treating a hormonal condition that they couldn't even define without circular reasoning. I mean, that's essentially what's happening here. The nice way to do this is to have medical association leaders grow a spine and say, okay, I'm going to get some flack from my LGBT committee. I'm going to get some flack from some of my colleagues who make a living off of performing double mastectomies on 14-year-old girls. That's just going to happen. But you know what? I'm doing it because I care about my profession. I care about public trust in medical authority at a time where trust in institutions is at an all-time low. I'm doing it because I took an oath to protect and enhance the health and welfare of patients, not just my own, but all Americans. And I would be betraying my own oath and my own role as a leader in the medical field if I continue to pretend that there's no problem here.
Welcome, Leor Sapir, to the podcast.
Thank you for having me.
So you've been writing great pieces, as always. Every piece that you write for mostly City Journal, the Manhattan Institute, I think. They're always wonderful.
Thank you.
And you've written two incredible pieces about the New York Times 6-part series podcast that came out recently called The Protocol, which deals with the Dutch protocol. Could you, before we get into the nitty-gritty, can you give the viewers who may not have listened to that podcast an overview of what they attempted to do and where maybe they failed?
Sure. So The Protocol is it's a 6-episode podcast that was published by the New York Times, 2 months ago, a month and a half ago, something like that.
Yeah.
And it attempts, well, I should say it's the product of 2 years of investigative reporting by Azim Qureshi, who is the New York Times, reporter on the gender medicine beat. And the podcast, I'm just going to call it The Protocol. It could get a little confusing if we start talking about the actual Dutch protocol, but I mean, that's why they called it The Protocol. But The Protocol is a 6-episode podcast series that tries to explain, as Austin Mitchell, the audio producer, who's also the narrator of the podcast, and Qureshi put it, how science and politics got so entangled on this issue. And of course, why that's bad for kids, for families, and for physicians, frankly, as well. And so that's kind of what they try to do. And, it starts out with, after the themes are introduced, there's some, I think, very important and good moments in the series, such as where Qureshi interviews 2 of the original Dutch cohort, a man and a woman, and interviews them, several decades after they had undergone early intervention with pubertal suppression and hormones and I think surgery, but I'm not sure about that.
Yeah.
I believe so. Yeah. As I said, I wrote this in my first piece too. There were some really good moments in the series, and it's not. I don't think it's all bad. But that being said, on the whole, I found it quite disappointing.
Before we move on, because you're talking about FG, who was patient 0 in the puberty suppression experiment. This is a woman. She was a butch lesbian, very gender nonconforming, and they put her on puberty blockers, gave her testosterone, did some kind of rudiment, like the metoidioplasty genital surgery. And then Manon was a boy, had his puberty blocked early, and now he's living as a woman. Did you find that part of the podcast good? Because those stories were really unsettling to me. Those stories were 2 adults who missed out on a lot of opportunities and had their life sent in a direction by this medical experiment and they don't seem to ever, the podcast never grappled with what that experiment took from them.
I think that's right. There were, for those of us who know this issue well and who have followed and who have really thought about it and read about it a lot, there are obvious questions that never get raised there that are absolutely fundamental. Questions dealing with assessment. In the case of FG, for example, the fact that FG seems to have had a father who was disapproving, kind of from a traditional background, disapproving of his daughter's masculinity and possible same-sex attraction. The disapproval of masculinity stuff, I think, was very briefly mentioned, of course, never explored. All the stuff about same-sex attraction, I mean, not just here, but throughout the entire podcast, was almost entirely ignored.
Yeah.
It's just astonishing considering that one of the, I think, most important criticisms, academic criticisms, popular criticisms of so-called gender-affirming care is that there seems to be quite a lot of evidence that most of these kids, especially the ones who first manifest these feelings and behaviors very early in childhood, would grow up to be gay. And that, kind of the protocol evolved out of kind of a therapeutic culture that that saw the struggles of being gay in a society that was not fully accepting of gay people as something that should be pathologized, and basically the burden should be shifted to the individual to conform in their body. Now, of course, there are people who would disagree with that characterization. We can talk about that, but it is a major criticism of this protocol. And it's one that has a more than plausible basis in the scientific literature. And so for the New York Times to completely ignore it is just, I think it's just mind-boggling for me.
Yeah, with FG, there's that part in her story where she says she befriended a girl and they both thought they were boys and they played sports with the boys, and then that girl just turned out to be a butch lesbian.
Right.
And you just think, does she realize how close she came to being the same?
To me, that was a crucial point in the protocol, the podcast, where they could have gone in depth. They had an opening. When you're in a podcast and you could go there. You know what I mean? What about the road less traveled? Funnily enough, FG is the same age as me, as far as I can make out. And so I particularly identify with FG, born female, and I just felt that there's, if I was to call, the protocol anything, I'd call it, as I was saying earlier, the veneer, because it's always skating. It gives this kind of feeling veneer of in-depth analysis, and then it doesn't give it, which is a lot more insidious. If it was just saying we're skating over it, we're skating over it, this is a whistle-stop tour, you'd go with it. And all this as if it was going in depth, and yet it wasn't at the crucial point.
And that, I think, is what troubled me the most as well, is that really the most, and I talk about this especially in the second piece that I published the other day, is that the most foundational questions in the field, the ones that any good investigative journalist should be at minimum curious about, if not writing profusely on, go almost entirely ignored in this 6-episode podcast series. And instead we get, kind of dozens of minutes of interviews with these two, kind of Dutch protocol patients. And I'm not saying there should have been no interviews. I'm saying it's a matter of balance, right? Because anybody can, and of course some defenders of the podcast will say, oh, there's editorial choices and you can't cover everything. But I'm sorry, but to include 30 minutes of interviews with these two young adults, and to ignore all of the foundational questions of the field is not, a matter of, well, we didn't have time. That is a deliberate editorial choice. And it just strikes me as a failure, a journalistic failure to explore the issue and present it to the public in all of its raw, naked, uncomfortable realities. So, more on the FG theme. It was clear that FG lives alone, that FG lives with cats, Not that I have anything against people who live alone with cats, but a person at that age who is not married, doesn't seem to have a stable partner in life. I mean, it's worth at least mentioning that
Well, we
the
know
reason.
that, Leor. We know from other research about
Right.
FG that FG hasn't sustained long-term relationships,
Right.
has shame.
And she
about
felt shame about her
genitals.
genitals. It's just what
Yeah.
As
Yeah,
Hakim
shame around
describes
the
as
genitals. That's right.
transgender dysphoria. Like she transitioned from gender dysphoria to what As calls transgender dysphoria. But Manon is the same. Like that kid, well, he's 30. He's talking about, there was a part where he says, all of my friends are having babies, and I understand that I'm now understanding what I gave
That was
up,
so
and that's having an impact on my life now. But he was a kid and he signed away his fertility, and we all know that they can't possibly understand that.
Right.
And yet again, but I do think as well, maybe Azine and Mitchell, they shouldn't have. I would have been uncomfortable if they had kind of grilled them. Do you
Well, so
understand
that's
what you
right,
lost?
and that's I think that's the dilemma here. Just before I'll say something about that, I just want to just close off the point about FG, which is, I think at that point it would have been useful for Qureshi and Mitchell to say something to the effect of, "Look, the reason why this protocol was proposed for kids in the first place is because the Dutch observed that the adults, even though they reported being subjectively
Yeah.
satisfied, they weren't doing well in these kind of important areas of life and social functioning, including relationships and so forth." Now, I do think that they mentioned that at some point in the podcast, but this is, I mean, to not pause for a minute and be able to say, after concluding the interviews with these two people, to say something like, there were some red flags, and then connect it to how the Dutch saw these adult patients and said something isn't going well here, I think fails to provide the relevant context for understanding how did we get to a pediatric transition in the first place. But look, I mean, this is a dilemma, right? And I think you have to give it to Qureshi and Mitchell that they had access to these two young people who, to my knowledge, haven't given interviews before. And there's only so much you can do, as you just said, Mia. You're not going to start asking them very intimate, probing questions, and you also don't want to be, you don't want to repay their generosity by kind of questioning their self-reported narrative too much after the fact. So a balance has to be struck here, and I don't entirely blame Qureshi and Mitchell for not probing a little bit deeper, but to some extent I do, because there's so much at stake here, and we'll get back to this, I hope, but this has been a constant theme of New York Times reporting on this issue: the complete unwillingness and incuriosity about the deeper ethical questions. Everything, the ethics of gender transition are always reduced to questions of satisfaction and regret. If a patient says, "I'm happy with the decision," 20 years later, therefore, the conclusion seems to be that this was medically appropriate and there's no ethical problems involved. That's not how medicine works. That's not how bioethics works. Read the HHS report chapter on ethics, and you'll get a much, much deeper discussion of why the question of regret and satisfaction, though important, are not definitive. They don't exhaust the question of the ethics of this issue. And so I think the way in which the New York Times presents these stories of satisfaction is, look, these people are satisfied. They say that they're happy with their decision. Case closed. So for some people, clearly this is the right decision as kids. That's not how I think a serious investigative journalist should be thinking about these questions. It's obviously an important data point and has to be mentioned, but it's not the end of the story.
I always say some people were happy with the outcome of their lobotomies,
Many.
but that doesn't mean
some
that
families
lobotomies
too.
were
Right.
The families were happy, and some actual people were happy with the outcome. Doesn't mean that lobotomies is
right. But also, I mean,
ethical
we're
treatment.
as human beings, we know that we can sometimes integrate mistakes and integrate bad things that people do to us into our lives. We know that sometimes bad decisions lead to kind of good outcomes that wouldn't have happened if not for the original bad decision. When you speak to detransitioners, for example, you hear some of them say things like, Yeah, it was a bad thing. It should never have been done to me. And of course, I was harmed. But at the same time, it's not simply a matter of I wish none of this had ever happened, period, case closed, because they'll say things like, I got to know a lot of wonderful people throughout my transition and even detransition that I never would have gotten to know if I hadn't gone down this road. And those people make my life richer and better and so forth. So it's not black and white, right? I mean, and of course, the opposite could also be true. You can, so just as you can integrate you can integrate mistakes into your life story. You could also integrate good things into your life story that you shouldn't have done. So anyway, all of that is just to say it's so much more complicated than just he's satisfied, therefore it's medically appropriate and ethical, case closed. But that is how effectively the New York Times has covered this issue. And I mean, it really is just, it's a certain kind of superficiality. Yeah. They kind of impose this floor on how deep they're willing to go. And given the stakes, I mean, that just doesn't seem appropriate to me.
Yeah, you, in that second piece that you wrote, it was so satisfying to read that when the opening paragraphs of your second piece about the protocol, where you lay out all of the questions that the New York Times failed to address completely. There's too many, I think, for you to list them all. But my question is, can you give us an idea of what they failed to address? But then when I was writing about it as well, I came to the conclusion that largely they failed to really address the issue because they started from the wrong place. Right in the first 5 minutes, Azine tells us that, I don't know, in the 1950s, transgender people were treated as sexual deviants and mentally ill and couldn't get the treatment that they needed. And then along came these pioneers and they really listened to the transgender people. And then they gave them the hormones and surgeries to solve their pain. And off we go. So there's never any question that what Harry Benjamin, John Money, and all the rest did, that's the question to me is, right, was it right what they did? Should we be treating this medically, this mental disorder, with these medical treatments? But they start from the wrong place. They start that it is ethical medical care, and it's just a question of, should we do it to kids? And if we do, how do we do it? Is that why they missed all the points to you as well?
Yeah, I mean, I think that the historical background as presented in the podcast is very, very thin, and it's frankly quite sanitized. Look, I mean, I've also heard people giving historical accounts of gender medicine that are also kind of very thin on the other side, right? Just presenting it as nothing more than just a bunch of deviants who are trying to sexualize kids and so forth. I mean, that's also not correct. Clearly, this is a case of, doctors, most of whom, not all, but most of whom had good intentions. This was a case of doctors seeing patients not doing well. Those patients were absolutely insistent that they knew from a very young age, and that if they had only been able to, bypass male puberty, then they would pass, and their passing would result in a much better life. And I mean, when you're a doctor and you hear this, and you don't have, kind of years of exposure to a culture that has normalized these procedures to draw on, you could be forgiven for thinking that this could actually be a good idea. But of course, there's a lot of messy realities there. There's John Money and his experiments. There's Christine Jorgensen. I mean, it's a lot messier than what we get in the New York Times podcast. And I think it could have been done even in a very short period of time. I think that messiness could have been brought out. So sorry, I know maybe I didn't answer completely your question, but I mean...
No, you did. So that's good. But tell me can you give us a brief overview of what they missed?
Okay, so, and I think in order to get there, we first have to just understand what it is that I mean by this term that I've been using, golden mean fallacy.
Oh yeah, I love this.
So until a few years ago, I think there was by and large, with a few, I think, notable exceptions, there was an unwillingness in elite liberal opinion, kind of New York Times and so forth, to recognize that there was a serious problem here with pediatric transition. I think over the last couple of years, what we've seen is a growing awareness and willingness to say publicly that, yeah, some things have gone wrong, some, the evidence was exaggerated, US medical associations are not in line with what's happening in Europe, and systematic reviews this and systematic reviews that. And of course, the Cass review was a very pivotal moment in kind of forcing the Overton window to open a little bit. But where things are starting to get settled now, where things seem to be moving, is towards this position of, there's a way to do this right. That things have gone wrong, and ROGD was ignored, or they never call it that, but ROGD was ignored, and and clinicians were far too quick to approve kids for medicalization and to take kids at their word that they really are trans. But at the same time, the reaction to that from Republicans, I think this is kind of axiomatically assumed throughout the New York Times podcast, that the reaction from Republican lawmakers to impose age minimum laws, or as the Times like to call it, bans, that's misguided. I don't think there's any ambiguity in the podcast that the Republican solution to the problem is simply politically driven and misguided, right? One way that comes across is by Scott Leibowitz ascribing just absolutely nefarious motives to every last Republican who's been working on this issue. It's all just transphobia, and of course he receives zero pushback. The New York Times never interviews a Republican who has proposed, sponsored, helped pass one of these laws. It's just kind of, as I wrote in my first piece, that the presence of Republicans is like this evil presence at the background of the podcast that provides the dramatic backdrop for the individuals who do have agency and whose kind of dilemmas do matter, right? The Laura Edwards-Leeper and Scott Leibowitz and the detransitioners and so forth. So the Times obviously wants to not get anywhere near the Republican solution, which is just assumed to be wrong and bad and ill-motivated. But at the same time, they now can't ignore the kind of the brutal realities of the Johanna Olsen Kennedy approach, right? It's just kind of gender affirming whatever kids want and child-led. And so where does that leave us? That leaves us in a situation where we say that, okay, well, for some kids, this is right. And if only we had more responsible clinicians that did actual mental health assessments, and that's, I think, where Laura Edwards-Leeper comes into the podcast, because she represents kind of the bridge between the Dutch protocol and its insistence on assessment on the one hand, and the abandonment of that model in the United States. And of course, the way in which Laura's role is presented is, there was never really any chance that this would succeed in the United States because of these structural factors, the lack of proximity to clinics and so forth. Anyway, I don't think that it's possible to come away from this podcast and think anything other than, oh yes, there has to be at least some good way to do this. At least some kids should be able to get it. And so what I've been saying over the last few months, because I've seen this trend emerge in elite liberal opinion, is it can't be true that there's a middle ground, a reasonable way to do pediatric gender medicine simply because you don't like the other two options. If you do think that there's a middle ground, you have to be able to justify that middle ground. There has to be three things. There has to be, first of all, a plausible clinical rationale. What is it that we're trying to treat? Are we treating gender dysphoria? Are we treating transgender identity? If we are treating gender dysphoria, how good is the diagnosis of the DSM-5? Even if clinicians are following those criteria, are the criteria specific enough? Is there diagnostic specificity? And here I would, for example, point out that the Cass review, I think quite clearly says, both the interim report and the final report says, no, there's not enough diagnostic specificity, because in fact, you can meet all the criteria for gender dysphoria in adolescence, and yet the cause of your gender distress is something else. It could be a maladaptive mechanism to underlying mental health problems, whatever it is, and therefore transition is not going to be the right path for you. And so that issue has to be explained. What do we know about the condition's natural history? Does it resolve on its own? If so, in whom and how long does that take? What are the other, what are the factors that intensify it, that reduce it? All that kind of stuff. And of course, what's the goal of treatment? Is it to treat a condition, to make the condition go away or to mitigate its symptoms? Or that's kind of the pathological framework that's adopted in the DSM-5. Or is it to help kids who are assumed to be healthy achieve their autonomously posited embodiment goals? That's kind of where the gender medicine industry has drifted to in recent years. And so all of these questions, and of course at the most fundamental level, are the key concepts that make up the field: sex assigned at birth, gender identity, transgender adolescent. What do these terms mean? Do they have a scientifically valid definition? To what extent are they at play in this area of medicine? And if the answer to those questions is that no, these terms are not, they're not well defined, they don't have scientifically valid definitions, is that a problem for the field? Imagine if endocrinologists were treating a hormonal condition that they couldn't even define without circular reasoning. I mean, that's essentially what's happening here, right? And so that's kind of the first category of issues, that is there a plausible clinical rationale? And of course, that's never explored in this podcast.
Can I just come in on this, because it's a key point? When you look at, like, let's say JIDS was closed in the UK and they banned puberty blockers, and now there's a massive regrouping and rolling back on all that, I feel they never addressed what you've just articulated there, Leor. The clinicians never addressed it, and the new regional centres in the UK are not addressing the fact, what are we treating? What is our clinical outcome here? And I'd like to add a third point. So some clinicians, I've spoken to enough of them to know, some of them have this kind of vague idea, and it's more vague than it should be, we're treating a condition called gender dysphoria and we're seeking desistance. That's some clinicians. Some clinicians are more way out there, and they're just saying embodiment goals, child agency, lead them to it. And I would say the majority are saying, if there's a gender identity within them, we're not crushing it. And we're gently allowing this bonsai tree of an identity to emerge, you know what I mean? Almost like an orchid, and that it has to be very, very carefully not crushed. And the clinician, it's like they've imbibed these cultural ideas. And because what you articulated has not been clarified anywhere, the clinicians are really vague about it. They're really vague about what are we meant to be doing. So they stay away from it. They talk kind of vaguely. They try to avoid it. I'd love if we could kind of sing that from the rooftops, us as a movement, for one of better phrases. What are the goals here? Like, in all these children, are these clinics seeking desistance? Because desistance is actually the healthiest for your body, arguably. But if you believe there's a psychological, gender identity within you, you don't think that. So I don't know if I'm rambling, but you follow me? It just feels crucial.
No, I mean, there's so many contradictions in this field, it's hard to know where to begin, but a good example of them is nowadays, it's not even gender dysphoria, it's gender incongruence, right? The ICD-11 classification. In fact, WPATH itself recommends using gender incongruence. But if you look at how gender incongruence is defined, which is a mismatch between gender identity and sex assigned at birth, that is also exactly how the word transgender is defined. Okay, well, if now we're saying that the goal of endocrine and surgical interventions is to treat or manage a condition called gender incongruence, then it also follows logically that we're trying to treat or manage a transgender identity. And so we're trying to end the incongruence by bringing two things into alignment. But if we do that, then both in the case of gender incongruence and in the case of transgender identity, aren't we essentially getting rid of the transgender identity? Isn't that logically the goal of these interventions, is to make somebody not transgender anymore? Because now their body has become aligned with their gender identity. So they're now cisgender according to the definition.
Exactly.
And of course, this would be their own definition of conversion therapy. Yes. So you can see how, like, once you just take their own definitions of these core terms, you start applying them in the sequence of clinical reasoning, you see that none of it makes sense. And what I'm trying to say is, these are not just kind of these academic curiosities, these esoteric questions that that you and I can discuss on some obscure podcast, right? Not that this is an obscure podcast. I'm not saying that. But that's not what this is about. This is absolutely central to the field of pediatric gender medicine and to not even show curiosity about these questions when they have been discussed so much in the academic literature, even in scientific literature, and to say nothing of kind of popular discussions and commentaries, I think is misconduct. I mean, here's a good example, right? Take my interview with Laura Edwards-Leeper. I asked her about these foundational concepts. Is sex assigned at birth? She says, yes, doctors assign sex at birth. Why? Because of intersex conditions. You know, I didn't want to push further there, but we all know kind of where that argument fails, right? Because even if you believe that disorders of sex development show that sex is not assigned at birth, or sorry, is assigned at birth for some people, that certainly doesn't apply to the vast, vast, vast majority of people who identify as transgender who don't have a DSD. So that's number one. And then I asked her, what is gender identity? Some people say that the definition relies on circular reasoning and stereotypes. And her answer surprised me. She said, oh yeah, no, it's a social construct. And there isn't a clear definition of it. And yes, it does rely on stereotypes. So here you have the clinician who is a stand-in in the New York Times podcast, a stand-in for how to do pediatric gender medicine the right way, a moderate voice, openly admitting that the central concept that justifies these medical interventions is a social construct that relies on stereotypes and doesn't have a clear definition. How much more do we need to get, the New York Times to ask the question, what does this mean for the field as a whole?
Well, she said something, it's not imprinted in my mind, but on that, she said something like, but it is a social construct and it is based on stereotypes, but it can cause a lot of pain if people aren't allowed to be who they feel themselves to be, and therefore we should medically transition them. And so she's basically saying it's a response to people not accepting gender nonconforming behavior.
Right.
She's putting it on society. It's society that won't accept it. So we better medicalize their bodies.
That's right. And a friend and colleague of mine, having read my interview with Laura, said, I would be a lot more impressed if she just came out and said, or people that share her mindset just came out and said, yeah, we're medicalizing gender nonconformity.
That's all it is.
And what's the problem with that? Right? I mean, at least own it, right? I mean, because that's really
she very close to that, though, I thought.
Well, she was wishy-washy all around, I found, talking around it. Can I just, because this brings me to my point about the golden mean fallacy.
Sure.
So the way I was looking at the spectrum is I'm on one end where I think absolutely none of these kids are trans, so therefore we should medicalize none of them. And then Joanna Olson Kennedy is on the other end, and that part in the protocol where she says something like, if assessment could show who was going to persist and still identify as trans in 20 years, I'd be all for it. But it can't show that, so let's medicalize everyone. She basically says that assessment does nothing, so let's just medicalize them all on the first appointment.
That's right.
And then Edwards-Leeper sits in the middle, where she believes that the assessment, if you do it, you've got like your report of 30 pages and you spend months and months, you still can't figure out who will persist and who will desist. But everybody feels better about themselves, the parents, the therapists, everyone. And so that's the best approach. She embodies the golden mean. She is the golden mean. And you say that's the most dangerous, or as dangerous as the Joanna Olson Kennedy approach, right?
So yes and no. And here I think we need to be fair to Laura and what she actually does. So she doesn't, as she told me in the interview, she doesn't claim to have the ability to predict who is going to go on to have a permanent trans identity and who will, and, kind of by the logic that I think the industry has adopted, therefore who will benefit and who will be harmed, right? And that's not what her assessment is all about, right? She said, I used to do gatekeeping when we first started, but that very quickly kind of went away, right? So, and part of this is a pragmatic adjustment to the field in which these kids and their parents can go anywhere they want easily to get hormones. And so, if they're going to come to her, it's hard for her to present herself as somebody who does kind of rigid gatekeeping because there's just nobody's going to come to her, right? So part of it is a pragmatic response to how the field has as a whole has evolved. But look, here's what she told me. She says, if the kid goes to a gender clinic, they're going to get medicalized right away. No questions asked. If they want it, and as long as the parent's on board, even one parent is on board, then it's just going to happen. But if they come to her, they're going to get, 20, 30, 40, whatever hours of talk therapy in which she explores, who this kid is, what else is going on in their life, do they have ACEs in their back, right? Adverse childhood experiences. What is their family situation? What's their school situation? And so she does this kind of, as she put it to me, a holistic assessment of the kid. And then she also, what she does is she tells the parents, look, I've seen cases of kids who get medicalized and 10, 15 years later are doing well. We can get back to how she knows that, but are doing well. And your kid doesn't fit that pattern. There are a couple of things that are different about your kid that make me think that they're not going to be one of those successful cases. So, it's not as if Laura is there, then kind of stamps a piece of paper and says, rejected. No, that's not her role. But she does equip the parents with this report to say, you should think very carefully about this, because from my clinical experience, your kid does not seem to fit the mold of a kid who would benefit from this. And so then the parents can take that report and think about it, use it as a basis for discussion with their other providers, maybe as a discussion at home with their own kid. So I don't want to suggest here that what she does is totally useless or is just nothing more than smoke and mirrors. No, I do think that it has value, and it's definitely better than the alternative. But once you start to get into these kind of more difficult questions of, well, how do you know that they benefited? What do you mean by benefit? And, what expectations or assumptions are you planting in the minds of a parent when you say, I'm doing an assessment and I'm telling you that your kid fits the mold, right? Then you start to get into these more difficult questions of, on what basis do you think that this is a benefit, and so forth. So that's why I'm saying, we can recognize that there is a value to that approach relative to the Olson-Kennedy approach, but that doesn't mean that it's a clinically responsible approach.
Yeah, I mean, that's the whole thing in the protocol, right? Where they're talking about the Dutch. The Dutch did the assessments. The Dutch did it well. The Dutch had this whole year-long process, and they only chose the ones who would benefit. But then if you look at the Dutch research, they all progressed. You're doing this assessment, you take all these kids, but they still all go from puberty blockers to cross-sex hormones. They still got the complete reversal of the desistance and persistence. So the assessment does nothing, does it not?
And it's a little bit worse, arguably, because I've met so many detransitioners who said, I did have therapy. And, it did seem to be kind of in depth. Now, when I talk to them, I don't believe it was, but it seemed to be. And so they feel really worse. They blame themselves further. Richie Herron, famously had 100 sessions with his therapist. You know what I mean?
And it reassures them, does it not, that they think they're making the right decision?
Yeah, it reassures them, but it also makes them feel that it's almost it's been checked, rather than it's legitimizing what I would consider a harmful medical intervention. And I don't know what
I think it can. I don't want to be unfair to Laura here. I think it definitely can do that, for sure. But I don't think it necessarily has to do that. I think, if you're working with these kids, and Stella, you would know this much better than I would, but if you're working with these kids and you know how easy it is for them to go get hormones and to get affirmed at every corner, you, as a responsible clinician, you can't just shut them off and say, nope, sorry, you're not trans and all that kind of stuff, right? They're not going to listen to you. They're not going to come back for a second session. You're going to get nowhere with them. And so you have to provide them with some kind of alternative path that they'll buy into, that doesn't try to talk them down from where they are necessarily, but that does try to slow things down, get them to think a little bit more. And there's value in that. So look, I mean, if Laura's role in all this was to be the person who takes the rubber stamp and says rejected or approved, I think we would have a lot more accountability to demand of her. But in a scenario in which everybody and their mother is approving these kids for hormones with no questions asked, and you have a few clinicians who hold themselves out as gender clinicians and who take a more responsible approach, even if we don't ultimately think it's a good approach, but it's at least more responsible, I think we do have to recognize the value in that.
So then you don't think my understanding was you thought the assessment model was more dangerous than the affirming model. Did I misunderstand? Forget Laura, but just in general.
Yeah, I don't know that it's more dangerous. I mean, it's hard to see how anything could be more dangerous than the child-led model, right? I mean, that is the epitome of medical irresponsibility. I don't see how it could be. But I think where it gets dangerous is that it and this here we're going back to the protocol, to the podcast. If people don't understand what assessment really is, what this process really involves, what it tries to do and what it doesn't try to do, they are likely to think that, in fact, Laura is sitting there and saying, okay, I have these criteria, they're scientifically validated, and if you don't meet the criteria, then I'm not going to approve you and you're not going to get hormones. That is not what assessment is, right? If you think about like going to a doctor for a diagnosis of cancer, they could take a biopsy, they could look at, do pathology, all that kind of stuff, and they can tell you it's cancer or it's benign, right? And if it's benign, they're not going to give you chemotherapy even if you want it. Obviously, that's not the case here. And so my complaint, or where I see danger here, and the middle ground fallacy, the golden mean fallacy is exactly this, is that if the New York Times is telling people there's this middle ground and it's called the assessment model, I'm pretty sure that's the term they used, and they don't explain that the assessment model doesn't actually try to figure out, doesn't actually try to weed out the kids and say no to some and yes to others. No, it's all it does is just slow things down and give parent a little bit more information, but ultimately it leaves the decision up to the kid and his or her parents. That's very misleading. And I do think that the Times should have done a better job and asked better questions of Laura, just in terms of like, what exactly is it that she does and how different is it really than what's going on in the gender clinics? Because yeah, it's different, but it's still, as Laura very clearly explained to me, it's still within the informed consent model. It still ultimately comes down to, does the kid want it? If so, and at least one parent is on board, they're going to get it. And so that, I think, needs to be explained.
Does Laura give any numbers about like how many, persist in her clinic and how many desist?
I don't know that she has numbers. I mean, I have spoken to her about this in the past, and she says that, very, very few of the kids that she's treated have regretted it. Now, there's problems with that observation, right? Number one, it's not a systematic observation. It's largely based on patient self-report, right? If patients tell her they're happy, then she knows it. And if patients never tell her anything, then she won't know it. If patients tell her they're happy, but they have big problems in their lives and transition made those problems worse or didn't solve them, they may not tell her about it, right? So that's exactly why you need this to be done within research settings, if you're going to do it at all. And you need to not just rely on kind of the self-report of select patients to their clinicians. As you know, Lisa Littman had that paper from a few years ago on 100 detransitioners that said 3/4 of them never reported back to their gender doctor after regretting what happened. So it's not these kind of clinical anecdotes based on the opinion of clinicians, they're not worthless. Of course, they have some value. You do have to take them into account to some extent, but they are hardly conclusive evidence of benefit or of, extremely low regret rates or stuff like that. On the other hand, you would expect that somebody like Laura would have fewer cases of regret for her patients than someone like Olson Kennedy. I mean, I think it follows logically that the slower you go, the more rigorous the kind of the talk therapy that you do around these decisions, the more likely you are to get at least some kids and some parents to second guess what they wanted to do and maybe to wait or not do it at all.
Yeah, the ideal is not do it at all. That should be everyone's goal that everyone lost sight of. I love Az Hakim's approach the best, when he put those wanting to transition with those who regretted at the Tavistock way back in the 2000s. And just hearing what the medical pathway could and could not do for you and what the complications were, meant that like 98% did not transition, and that remaining 2%, again, not solid science or anything, but they seemed to go into it with more realistic expectations and therefore probably did better.
Yeah, I mean, that's a good point, right? If you're going to base your decision on these kind of clinical anecdotes, you should have access to the full range of information, including from people who have gone through it. But look, I mean, this, just to kind of pivot a little bit, even though, because Laura is not the one who prescribes, the burden of the informed consent process is not really on her. Nevertheless, she does, as she told me, she does do some of the informed consent process. She gives parents information about what we know and don't know about these drugs, because I'm sure that these parents will have read article after article and NBC Out and so forth, saying how amazing gender affirming care is and supported by all medical associations. It would be interesting to know if she ever took a parent and said, look, you may have read, because she told me that parents come in having read a lot on this topic, right?
Yeah.
Has she ever actually sat a parent down and said, look, I know that you maybe have read all these articles and you've gotten a very favorable view of what these medications can do and how safe and effective they are. Do you know how evidence-based medicine works? Do you know what a systematic review is? Do you know that there have been a dozen of them and every single one of them has found that the quality of evidence is low or more often very low? Do you know what that means? How do you start to make sense of, on the one hand, people citing these individual studies that claim to have found benefit, but on the other hand, you have these kind of scary sounding scientific tools called systematic reviews and meta-analyses that actually find that those studies are not reliable. I wouldn't assume that the average parent coming in for a consultation understands how all that works. And look, I mean, this speaks to kind of the second category of issues that anybody who's trying to avoid the golden mean fallacy has to address, which is, okay, you acknowledge that the evidence to support kind of the child-led model is very weak. Is there any evidence, credible evidence, to support even the most conservative approach, the approach that supposedly relies on on lengthy mental health assessments and that has certain age ranges, or at least tenor ranges for starting certain medications and so forth? And of course, the answer to that is no. There is no credible evidence to support that. The Dutch protocol, which is based on the Dutch study, or vice versa, famously is a very flawed set of research findings, a lot of methodological problems. They have been evaluated in systematic reviews and found to be wanting. And even I think, so let me zero in on one particular issue here, which I think is really important, and that's the question of what puberty blockers are for. Maybe I should have asked Laura how she explains the purpose of puberty blockers to patients and their parents. But as you both know very well, the Dutch said blockers, on the one hand, they have these kind of desired therapeutic effects, which is to bypass, let's be honest, male puberty. Because it's not clear why they even gave them to girls, to be honest. But to bypass male puberty, the effects of which are pretty much irreversible. But crucially, it's also part of the diagnostic process. It gives kids at a very vulnerable time, when their sexuality is starting to emerge, when their sense of identity is starting to emerge, it gives them time to think. And it's that, I think, this is my interpretation of the Dutch protocol, I think that the time to think rationale carried the entire ethical weight of the experiment on its shoulders. Yeah. Because if you say that, no, this is actually the first intervention in a cascade that is going to follow for almost 100% of these kids, all of a sudden the ethical calculation is very, very different. And so the collapse of that rationale, the fact that we know now that the vast majority of the kids who start on blockers go on to cross-sex hormones, and the fact that the leading gender clinicians in the United States themselves have abandoned that rationale, right? And I give a link to the Yale report, and how they say that the systematic reviews were wrong to evaluate blockers and hormones separately because they're two parts of the same intervention. That's what they say. They've completely walked away from the totally reversible time to think rationale.
Okay.
Does that not matter here? I mean,
Can
that
I?
was a central
Yeah.
part of the Dutch protocol, and it has been completely discredited and abandoned by the very clinicians who practice this area of medicine.
I'm more agitated as a clinician, and having, I did my degree and I did my master's, and I know how we clinicians work, and we're not up to speed on systematic reviews, and we just aren't. I'm in the culture, you know what I mean? Nobody is now. I'm in gender world, I am, but nobody else is. So I give Laura Edwards-Leeper a pass on that, because I know how clinicians work, and you're in the water, if you follow me, and you're just working psychologically with the person in front of you. I don't give a pass to the journalists. I think that's their
Yep.
job. That's
Right.
what they should have been highlighting. That's what they should have been doing with the protocol. And I would be a lot more critical of Qureshi and Mitchell for allowing themselves to present a protocol 6 episodes. They had a huge opportunity to really do something pioneering and with integrity. And it really could have just raised questions. They didn't even have to answer them, but they could have asked some good penetrating questions. I particularly took issue with the way they positioned Jamie Reid and with the way they positioned the parents. I just felt like that phrase, deep down, you're quite shallow. I think it moved from that to, oh, this feels actually cynical.
Yeah.
It moved into cynicism, I felt, as the time went by and I was listening to it.
And correct me if I'm wrong, but they never grapple with the complete collapse of the entire foundational rationale, do they, in the protocol? I don't recall them ever.
No, I don't think so. I don't think
Yeah.
so. I mean, so
Yeah,
that is missing, and I mentioned this in my piece, right? That even though they do mention in very brief terms, I think in one sentence they mention some of the methodological problems. Not necessarily even the most important ones with the Dutch studies. They never take a step back to say, wait a second, what does this mean that this whole medical intervention protocol was rolled out internationally, not just in the Netherlands? And these studies were cited, and to this day continue to be cited as the foundational research of the field. And yet it's
that was their
research that
story.
borders on it's research that borders on fraud. I don't see how you could see it otherwise. I mean, this should never have passed peer review, let alone become the basis for invasive, irreversible endocrine and surgical interventions on minors.
But let me just say one thing, because they ended it, episode 6, right at the end. You've made it all the way. You've listened to everything. And don't they end it with De Vries saying, I'm very proud of what we created here, and I think we really need to protect it. And that's the end.
I think you're right. I think that's how they end it. And, that last episode where you have kind of brief audio clips from detransitioners interspersed with parents who say how amazing the care is, and people who say how they got it and they're so happy. This was the only time that they actually heard from detransitioners
and
throughout
almost
the entire
none.
series.
Weren't there like 2?
And they were very, very,
and
yeah.
They don't even say they're detransitioners.
And if you remember, that's right. And if you remember, they had this kind of call for submissions in the week or so leading up to the publication. It was almost frantic, like, quickly, we need something to fill this gap. The fact that they have a single sit-down interview with a detransitioner is, I mean, that's just journalistic malpractice. And even Laura said that really bothered her. How could you not interview victims of a medical procedure that is at the heart of the controversy that you're trying to expose? How is it that the voices of detransitioners are completely missing from this 6-episode podcast? That is just, I mean, it's just totally unforgivable to me. And another thing that I think is missing and had to have appeared, at least had made a cameo, is the role of U.S. medical associations.
Oh, yeah.
The way in which they have just completely botched their basic responsibility to acknowledge the weakness of the evidence, to facilitate debate, to not suppress their own members like the AAP did, like the American Academy of Child and Adolescent Psychiatry has done, like the American Psychological Association has done, not to suppress their own members when they try to raise concerns, to stop filing amicus briefs that contain blatantly false claims. I mean, what is there going to be no accountability for medical associations in a 6-episode podcast series? And these are, of course, the juggernauts of the American medical profession. These are the entities that are cited left, right, and center by all advocates of these treatments. Is it not worth at least spending 3 or 4 minutes on how, for example, the Rafferty statement of the AAP is just exhibit A of disinformation? And this is not even ambiguous. This has already been written up in 2 peer-reviewed journal articles, and it doesn't even get a mention in this podcast. I mean, it's just absolutely shocking.
And they didn't go into the incredible fraud of WPATH. They missed the Boe v. Marshall revelations, as far as I recall. I think they should have done a 6-part podcast on that.
They easily could have, right? I mean, I do think so. Okay, so first of all, in Ghoraishi's defense, she did write about the age, the Rachel Levin. Of course, it was all, kind of contextualized almost to death there, but she did get into that. And I do think, did they mention the WPATH scandal in the protocol? I don't remember. I don't
recall. I honestly don't remember.
But you're right. I mean, you would think that given the prominence of WPATH, the fact that this is the organization that sets the standard of care, not just here, but globally, this is the organization that all other medical organizations claim to defer to, that hospitals use in their own internal practices, that insurance companies use to determine which benefits are covered and which are not, state Medicaid authorities, the Biden administration deferred to WPATH. I mean, of course, they interview Marcy Bowers, and I think it's not a very flattering interview to Marcy. But the fact that this absolutely central actor in this whole drama was found without any shadow of a doubt to have suppressed evidence, misled not just the public and the rest of the medical profession, but even its own members. Even Laura herself says they told us that a systematic review is not possible, even though they knew that it was. They had suppressed it. The fact that they, eliminated age minimums under pressure and all that kind of stuff, even if it's mentioned in the podcast, to me, to not give this its own episode is just again, it's journalistically indefensible, because this is the epicenter of the whole controversy. Is there evidence? Has it been accurately presented to the public and to parents?
GenSpec's Bigger Picture conference series returns for its 4th landmark international event this September, the 27th and 28th, Saturday and Sunday, in Albuquerque in New Mexico. At this time, we're not just analysing problems, we're shaping the solution. We're looking for a way forward, and we've chosen the best speakers, the best leading thinkers of our generation to discuss how we can move the dial. With the theme Live Not by Lies, Conversation for a Culture in Crisis, this year's conference tackles one of the most urgent challenges of our time: how to speak truth in the face of conformity, confusion, and institutional pressure. As the politicisation of sex and gender continues to divide societies and derail thoughtful discourse and destroy loving and engaged families, this groundbreaking counterpoint to WPATH brings together the world's leading thinkers, clinicians, policymakers, lawyers, politicians, and psychologists to forge a path that is ethical, evidence-based, and grounded in reality. Abigail Schreier will expose the hidden consequences of bad therapy. Dr. Lisa Littmer will present her latest groundbreaking research. Lionel Shriver lays bare how society's fixation on trans identity distorts truth and undermines fundamental freedoms. Peter Boghossian will present Truth Over Lies, Bold Conversations in a Fractured Culture. Dr. Patrick Lappert will discuss the impact of trans surgery, while Dr. Quinton Van Meter will discuss the impact of hormones. Following defining events in Killarney, Ireland, in Denver, Colorado, in Lisbon, Portugal, we're now coming to Albuquerque in New Mexico. This is more than just a conference, it's a call to action. Join us for 2 days of unflinching honesty, rigorous evidence, and solution-focused collaboration. It's time to move the dial, and you need to be in the room. Visit genspec.org to secure your place.
And is it like psychologically, why did they fail so badly? Like I recently reread Mistakes Were Made, but Not by Me. If anyone has not read that book, that is what explains what's going on right now, I think. And it's this institutionally, or maybe even a zine, maybe the individuals involved, they failed because they backed something terrible. They backed a medical treatment that they didn't understand, and people have been harmed, and they can't face up to that mistake. So instead it's not that they willfully, they're not knowingly omitting all of the most important points. They can't let themselves look at it, because if they do, they have to admit that they played a part in something terrible. Do you think
Yeah, I mean, look, we can speculate about what the psychology behind that is, and I do have a few things I can say on that. One last thing I do want to say before I answer that question is about the treatment of Jamie Reed in this podcast, which, I mean, it's just unbelievable. I mean, you have I think, and here I'm psychologizing, maybe I'm wrong, but I think she gets that treatment because she's a heretic and not just a non-believer.
Yeah.
Because she was immersed in this. She did believe in the concept of transgender kids, and she did believe that this medical care was absolutely essential and life-saving and necessary. And through her own clinical experience and gradual immersion in the literature and the history, she realized that she had made a mistake. And she has so much credibility on this topic, like nobody else has. And that's what made it impossible, I think, for the Times to give her, a stage like they gave Laura, like they gave Scott. And by stage, I mean Laura and Scott got pretty much zero pushback, almost no critical questions. Whereas the only thing that Jamie got were critical questions. And frankly, most of the time that Jamie was featured in the podcast, it's when she had this awkward confrontation with the parent. I mean, give me a break. Is that newsworthy? Sure, it's newsworthy. Is that the main show? Is that what's really important here?
No.
Of course not.
Focusing in on one tiny error that was made.
Some stupid, yeah.
What's important here, like obviously, what's important about Jamie is what she saw at the clinic.
Yeah.
Is what evidence she had, the red flag list, the way in which the clinic's own endocrinologist said, we need to stop it, I don't know how to do it. Or we can't afford to stop now, we're already invested. The way in which, all that kind of stuff. There was the injuries that she described to some of these patients, the girl who bled through her pad, her jeans, the towel that had to go and be rushed to surgery because she was bleeding profusely. Like, you're not going to mention any of that stuff. You're just going to focus on this one mom who was already kind of crossed the Rubicon with her kid, and now she confronts Jamie in a parking lot. I mean, it's a classic example of, but other than that, Mrs. Lincoln, how was the play? Like, it's completely missing the point, totally missing the point of who Jamie Reed is, what she has to say, why it's important in this moment of time, and why people should be at least listening to her, even if not just taking everything she says at face value. And I'm not suggesting they should, but at least let her have a say. Now, look, in defense of Goraishi, this is, the interview with Jamie was done 2 years ago, right after she went public. Yeah. So it's definitely possible that, Azine and Austin, I don't know Austin at all. I've never heard him. I don't know what his view is on this, but it's definitely possible that they have changed their mind about certain things since then. They just had this audio stuff that they wanted to include because they already recorded it. Okay, fine. I get it. But one last thing I'll say about Jamie Reed, which is I think really crosses a red line. They present at the end of the Jamie episode, they present the tension between Jamie going public as a whistleblower and the fact that she's married to back then a transgender man who is kind of ambivalent about Jamie's actions. And they just kind of leave it at that. Like, Jamie did this despite, her own trans husband saying that he benefited from this and all that kind of stuff. And isn't this an interesting dramatic contrast? This podcast came out 6 months after Roxanne detransitioned. That's Jamie's former spouse, detransitioned and came out publicly in the free press saying, I 100% support what Jamie is doing. And I think that the medical interventions on minors has to stop. Because even me as an adult, it affected me very, very negatively. And the Times never mentions this.
Right. And that's more than incompetence, though. That's deliberate. So then I think there's deliberate framing. They can't be that incompetent.
Maybe. I honestly don't know that it matters,
Yeah.
if it's deliberate or not. All I know is it is such a critical omission, and it so obviously skews the narrative and misleads the listener. It's just completely irresponsible.
I do think we, in the larger sense, are at a very crucial time. And I am very strategically minded, and I'm interested in where you think we should be going and how we should be approaching things. And, I'm very interested in history, and I've seen, the road to hell being paved with good intentions. I've seen, Ireland got split in 1922 by a very well-intentioned treaty that kind of wrecked the next 100 years. And, I've seen the Yalta Conference, 1945. I see, Neville Chamberlain waving his peace in our time, the politics of appeasement. You see the Molotov-Ribbentrop Agreement. Anybody who wants to look up any of those, there's a lot of agreements that happen. There's a lot of strategies that happen at these crucial times, the Yalta Conference being the big one in 1945. And so one has to be strategic about how we move now. And I think it's crucially important. And I really want to hear what you think, how we should be approaching this. I think, for me, I'm over the politics of appeasement, and I'm naturally appeasing, believe it or not. People wouldn't think that, but I am actually. But I'm like, no, now is our time to actually move in. If I was playing chess, I'm bringing the queen up now. You know what I mean? Now is our time.
Yeah.
So what do you think we should be doing, and how should we be approaching it? GenSpec, for instance, we positioned ourselves very clearly. We believe it's a mental illness. This is a harmful intervention. It should not be recommended by healthcare professionals because this isn't a healthy intervention. We've gone in and we've said,
for
where
any
do you think
age?
Yeah, I know, because it's a harmful intervention. It shouldn't be recommended as a healthcare intervention. There's free societies.
It's interesting to hear you say that, Stella, because as you know, there are accounts on Twitter that say that GenSpec's whole role in this debate has been to criticize. I mean, they say that about me and MI too. That our role is to criticize, that we're being paid by the industry to criticize pediatric transition in order to salvage and secure the lucrative market of adult transition from which our benefactors derive billions of dollars. I mean, it's just so unbelievably unhinged.
Jennifer Bialik wrote an entire chapter about how we're trying to trans kids, let alone anything else. Right. And so yeah, conspiracy theories will always live. But in the meantime, strategically, I'd love to hear how you think, because I'm very nervous of the politics of appeasement. I'm very nervous of.
I think that's a great question, and let me try to tackle that question by bridging from what Mia asked, and I didn't really answer, and is what kind of psychologically, where is elite liberal opinion right now? Yeah. What explains the approach taken by, for example, Qureshi and Mitchell in the New York Times and stuff? And again, recognizing I don't like to psychologize people because that's presumptuous of me, but I can speculate. Okay. I think where we are is a situation in which kind of elite liberal opinion says, look, there are adults, they identify as trans, they've gone through these procedures, they say it really helped them, and they say that they've felt like this from when they were very young. Now, the three of us know that there's a kind of a leap in logic from recognizing that to saying, therefore, therefore young people, kids, adolescents who say they're trans, we can know that at least some of them are going to grow up to be these types of people, right? That's a leap in logic that needs to be explained, it needs to be shown and justified. And of course, it's never shown or justified among those who just make the leap. And so I do think that we have to recognize at some point that people who identify as trans and say that they were benefited by medical interventions are not going anywhere. They're always going to be here, and they're always going to say, I knew this about myself when I was a kid, and if I had only been given the medications as a kid, my life would have been infinitely better. We can't just pretend that doesn't exist, okay? So I think it's healthy for us to start there. With regard to your question, what is the off-ramp? I think one way to think about, or where do we go from here? One way to think about that is, do we try to push back against this, kind of elite liberal mindset? Do we try to question it more? Do we try to get it to be more self-examining? I think there's value in doing that. I think we should be doing that. But at the same time, you also want to try to work with what you've got, right? Because there are kids right now and parents right now whose kids are going through this, for whom the syringe and the scalpel are imminent. They're right around the corner. It's a matter of weeks or months, and they need something now. They don't have time for us to get to a point where the New York Times has, front page New York Times, okay, we admit it. This is a medical scandal. It always was, and we apologize. That's, first of all, it's not going to happen. But if it does happen, it's going to be 15, 20 years from now, right? And meantime, you have all these kids and families who need help now. And so this has always kind of been my pragmatic struggle, because I work with people who say, lock them all up and throw away the key. For some of them, they mean it literally, but for others, they mean it figuratively, right? You need full force, use all the might of the Trump administration to go after this industry. And I get it. I understand the impulse. Trust me, I do. But I'm more interested in how can we minimize the most amount of damage as fast as we possibly can. And that means we need to get more and more of the people whose opinion matters, people in positions of influence and authority within the medical profession, within journalism, within law and policy. We need to get them to gently, back away from their very strong positions, to question things that they until now have not questioned, and to start letting in a little bit of sunlight. And that's a long, hard, difficult process. That you don't do that by imputing people's motives. You don't imputing them, bad motives. You don't do that by accusing them of harming kids. You do that by trying to be generous, trying to say, look, I understand why you trust your colleagues. Medicine requires trust and deference, right? Modern medicine can't function without that. And that's why I think that this metaphor of a broken chain of trust is so important, because it does generously offer an off-ramp to so many doctors and medical group leaders who have gotten kind of caught up in this stuff because they had misplaced trust in their colleagues, which is a reasonable thing for them to do, to place trust in colleagues, right? So I think, but I don't just think it's strategically valuable, even though I do. I also think it's also just true. Medicine cannot operate without a high level of trust, and doctors are constantly asked to trust their colleagues. And by the way, there's self-interest woven in there too, because when a doctor says, I'm going to defer to my colleague who's a gender clinician who knows this area better than I do, the implication is that when you're talking about, my area of medicine, I expect you to defer to me. So there's a lot of kind of self-interest involved there too. It's not just a matter of professional norms that have evolved over many, many decades. So, so what's ahead of us? I think if this is done right, and it's a very open question whether it will be done right, it's a stick and carrot approach. It's an approach where medical associations and, state Medicaid authorities and hospitals and individual clinics and individual doctors basically see a good cop, bad cop type scenario in which there's the hard way of the Trump administration with FTC action and DOJ investigations and naming and shaming and potentially going after, doctors with criminal charges and all that kind of stuff. And there's the nice way. And the nice way is the way that has been offered to them for the last 10 years by organizations like the Society for Evidence-Based Gender Medicine and GenSpect and even, frankly, health authorities in countries like Sweden and Finland, where they say, look, let's do this the way that we always evaluate medical practices. Let's do systematic reviews and let's follow them. Let's actually take seriously what it means to say that these are invasive treatments with risks that we know as well as risks that we don't know, and that they're only justified if we have compelling evidence that the benefits outweigh the risks, and we don't. And add to that the fact that there's lifelong implications here that children cannot even begin to comprehend, because no 13-year-old knows definitively that they're never going to want to be a parent. Give me a break. And so the nice way to do this is to have medical association leaders grow a spine and say, okay, I'm going to get some flack from my LGBT committee. I'm going to get some flack from some of my colleagues who make a living off of performing double mastectomies on 14-year-old girls. That's just going to happen. But you know what? I'm doing it because I care about my profession. I care about public trust in medical authority at a time where trust in institutions is at an all-time low. I'm doing it because I took an oath to protect and enhance the health and welfare of patients, not just my own, but all Americans. And I would be betraying my own oath and my own role as a leader in the medical field if I continue to pretend that there's no problem here. That would be the golden bridge. That would be the off-ramp. And then here's the really hard part, Stella and Mia. If and when that moment arrives, and we start to see a kind of internal discussion emerge and a reckoning, to what extent do people like us back off and allow them space to hash it out? To what extent do we encourage Republican lawmakers and Trump administration officials to back away a little bit? Because maybe by continuously going after these people, they're just making it much, much harder for the rational and sane elements within the medical field to be able to make their case. Because now, anytime they make an argument, it's always with this implied threat of potentially even criminal action behind them. And so it's going to be very difficult for doctors to take each other seriously in this type of environment. And so I think we're going to approach a point, maybe not this year, maybe not next year, maybe towards the end of the Trump administration, if we're being very optimistic, we're going to approach a point in which we're going to start to see this debate emerge in the medical field in a way that it never has before. And at that point, the ball is going to be in our court. Are we going to back off a little bit and let the medical profession sort itself out on this? Or are we going to continue pressing and pressing and pressing, possibly, not necessarily, but possibly to our own detriment? So I would hope that we can all be very strategic about that, because it's not an easy question.
I somewhat fear that something has been unleashed that it will be very difficult to rein it in. I agree that the heavy-handed attacks, the heavy-handed approach, while it may seem like putting out the fire in an emergency situation, it looks fragile to me. It looks like a fragile reprieve. But my last question, I suppose, is the off-ramp, the piece that I've just finished and should be published soon. Is the off-ramp not WPATH? Can we not just tell them, just throw WPATH under the bus, blame it all on them because it is their fault, and just say, oh, we trusted the experts, they betrayed us, they broke the chain of trust, it's their fault, and then everybody could wash their hands of it?
Yes and no. I've thought about this question a lot, right? If in fact this is a broken chain of trust, or even if medical groups have an interest in presenting this as a broken chain of trust, even if it's not, right? Even if they've known for a long time that this is a medical scandal, why wouldn't they do that? I think part of the answer has to do with the internal politics of some of these organizations, that they really do have very strong LGBT committees. And they run into serious collective action problems where you have a small number of extremely vocal, very highly motivated, and very well organized doctors pushing this stuff. And opposition to them is diffuse. It's clinicians who have a day job, who they just can't bring themselves to muster the same level of enthusiasm and fear as the clinician. So I think a lot of it is internal politics. But you would think that would be the off-ramp, to say WPATH misled us and so forth. Now, I think the problem is they don't sense that they are quite, to switch from the bus to the ship metaphor, they don't know that the Titanic has hit the iceberg yet. And I think they will know soon. I think there are members within these medical associations that know. But I think as a kind of a collective wisdom within these groups is not, okay, we're sinking. What do we do now? We're not quite there yet. And I think, unfortunately, as somebody who does not like to see heavy-handed government regulation, unfortunately, it's going to take some significant efforts from the Trump administration, serious, incredible threats, to get the medical profession, especially the medical associations, to understand that the iceberg has been hit. And now it's just a question of, how do you get off this ship?
Yeah. Thank you so much, Leor. I do think for us, anybody in our position, I think it's our job now to show a way forward, to be leaders, to show,
I think that's right.
Yeah, mentally, and to kind of bring forward solution-focused approaches to all of this sorry mess that we never thought we'd
Yeah, I
be
think
in.
that's right. And I was listening to one of your episodes earlier today in preparation for this call, and I just thought it was a great episode. And one of the things that you disagreed on was about the DSM
Who was
5
it
and
with?
whether it should have a.
Who was it with?
No, it's just the two of you.
Oh yeah,
I
that
don't
was
remember
good.
the.
Oh,
Yeah,
I love that one.
and you had a great debate. It was really fascinating. Great episode. I highly recommend it to your listeners
Thank
if
you very much.
if they haven't already listened to it. But think about this question of the DSM and gender dysphoria, right? Let's say a hypothetical scenario, because I think it's actually in the executive order, that the executive order on child mutilation, whatever it's called, I think explicitly addresses the DSM issue. Let's say that somehow the Trump administration managed to find a lever to put an enormous amount of pressure on the American Psychiatric Association to get rid of gender dysphoria in its 6th revision of the DSM. What's going to be the response to that? Obviously, it's going to be, oh, this was all politics. The only reason the APA did this is because it was responding to threats from the administration. Yeah, but the only reason the gender dysphoria appeared there in the first place is also politics.
Yeah.
And we have documented evidence of that. The people who put it in there themselves said, this is a political decision. It's not based on any studies or any scientific research or any clinical reasoning. It's purely in order to make sure that these people can continue to maintain access to insurance-covered interventions. And so that's kind of what falls to us to be able to explain these types of things. When the New York Times inevitably writes all of its articles about how this is all political and all politicized, we're the ones who have to continue beating the drum and say, you might be right, but we're only in this situation in the first place because of politics too.
Brilliant.
Brilliant.
Thank you, Leor.
Thank you, Leor.
Thank you both. And thanks again for this podcast. I mean, it's a really invaluable resource. So I'm honored to be here.
Oh,
Thank you.
Thank you.